welcome you all to this Durgabai Deshmukh Memorial Lecture 2023. Every year on this day, we gather here to pay our tribute to our founder, Durgabai Deshmukh. Durgabai Deshmukh was a freedom fighter, and at that time there were very few women who would be in this job. But after India became independent, she did not stop her fight, and she thought she needed to build institutions. So she became a famous institution builder. Many of you might have seen there is a metro station near Dharakwa, which is named after her. And you might wonder why it is there. It's because there is a college that was built by her. It's a very famous college, Venkateswara College. So that was one. She founded Central Social Welfare Board. She established many schools, and one of those institutions is, of course, CSD, Council for Social Development. And even these days, when we still debate whether trickle-down theory works or not, whether economic development is enough to bring about social change, social development, she emphatically said that no, economic development is not enough. In fact, even now, if there is one criticism that people make about Jawaharlal Nehru, who went for planned economic development, people say that she did not give enough importance to social sectors, to education, to health, and some of the things. So she thought that it was important to give importance to these things. She thought the women, children, Dalits, Adivasis, and minorities, they need special protection, special care, to have equal share in the economic development that our state was planning. I will not, I can go much, but due to time, I will not get into that. There is one brief bio in the lecture that you will get, you will find that. For this year lecture, we have got an eminent person who was a very, very famous doctor. Even now she's, of course, he's a doctor, but sometimes some sectors gain is some sectors lost, so he decided to get into public health. So he is now India's most noted public health expert, but he was a very famous heart specialist also. So we have got him as this year speaker for the lecture, and he needs no introduction to this audience, I guess, but briefly, he is also the founder, president of Public Health Foundation of India, where he is now an honorary distinguished professor. He formerly headed the Department of Cardiology at All India Institute of Medical Sciences, New Delhi. Under his leadership, PHFI has established 5 Indian Institutes of Public Health to advance multidisciplinary public health education, research, health, technologies, and implementation support for strengthening health systems. He was appointed as the first Bernard Law Visiting Professor of Cardiovascular Health at the Harvard School of Public Health, and presently served as an adjunct professor at Harvard, as well as Emory, Sydney, and Perelman School of Medicine at the University of Pennsylvania. He has over 570 scientific publications, such a huge the number, and published a book, Make Health in India, Reaching a Billion Plus. He was president of the World Heart Federation, is also an advisor to the governments of Odisha and Andhra Pradesh on health with rank of a cabinet minister. So you can imagine the kind of the great expert that we have to speak on this issue of public health, and all of us have gone through this corona and all. We talked about public health, what we need to do, what we did not do. So to give us a better idea, we have got him here. But before he gives the lecture, I invite our dignitaries of the desk to pay floral tributes to Durgabai Deshmukh, our founder. Please.
Can I take on? Please come. One minute. Yes, please. Thank you.
Today's function will be presided over by Professor Mujkun Dubey, President of Council for Social Development. He was Foreign Secretary of India a long time back, and he has been President here for a pretty long time. But he is also a noted expert on education. So with this, I hand over the charge of the floor to Professor Dubey. Please.
Well, I have the great honor of inviting Professor Nath Reddy to deliver this year's Durgabai Deshmukh Memorial Lecture. Sir. No.
Professor Dubey, other dignitaries on the dais, luminaries in the audience, ladies and gentlemen, I apologize for the inconvenience caused to the dignitaries because I'm going to be using a PowerPoint presentation rather than reading out my lecture, which in any case is in a printed format and is being circulated. It's indeed a great privilege to have been asked to deliver the Durgabai Deshmukh Memorial Lecture of 2023. Not only does it give me an opportunity to pay my tribute to the hallowed memory, one of the great luminaries of India, but also feel honored even more by the fact that many distinguished people have preceded me in delivering this lecture. As one who grew up in Hyderabad and fairly familiar with the hospital that she built and which is now named after her, and the Andhra Mahila Sabha which she established there, among her numerous contributions, I am indeed quite familiar with her interest in health, and therefore the topic I have chosen is related to health in terms of decoding and delivering public health, and particularly in the aftermath of a pandemic which is still with us in one form or the other across the world, having subsided in virulence but not announced its exit. I believe public health does deserve a consideration among an elite audience such as this. We know that health is one of the most undervalued assets unless it is seriously threatened by disease at the individual level or endangered by contagion at the societal level. But at the individual level, we must recognize that the health has an intrinsic value as well as an instrumental value. The intrinsic value is derived from a sense of well-being, ability for self-care, functionality, cognition, ability to undertake sexual and reproductive functions, leisure time pastimes, enjoyment of culture, and social interactions in a congenial fashion with family and friends. But the instrumental value of health is also important because it enables the individual to gain access and benefit from education, employment, income, uptake of skills, travel, competitive sports, performing arts, participation in them, and social interactions with extended networks. But in terms of where health is, we recognize that it has evolved in terms of its philosophical construct, particularly when we talk about health equity as something that every individual should benefit from and be assured of. We know that as we have moved from the utilitarian concepts of Bentham to justice as enunciated by Rawls and capability as expounded by Sen, we have now moved to recognize health as a right. Indeed, as Sridhar Venkatapuram says in his book, Health Justice, quote, a well-ordered society would ensure that all individuals have the capability to be healthy and at a level that is commensurate with human dignity in the modern world, which is their right. Therefore, when we look at the capabilities argument advanced by Amartya Sen and Martha Nussbaum, and we also recognize that it's not just one capability, but it is derived from a confluence of multiple capabilities, and that I shall deal with a little later, but what is now being called a cluster of capabilities or a meta-capability. Investing in health also is very important at the societal level. In terms of national and global economic growth, it protects and promotes productive human resources, reduces absenteeism and presenteeism at work, reduces expenditure on health care, creates employment, and catalyzes technological innovation. While a celebrated economist, William Beaumont, said in the second half of the 20th century, and indeed that mindset continued to dominate for some time even in the 21st century, that healthcare is a cost disease, that investments in health do not yield the returns that we see, for example, in industry, agriculture, or service sector. That healthcare is more a social obligation than a productive economic investment. But contrary to that, there have been several reports that have actually argued the case for health, even as a productive economic resource. And when we look at health, we know that while we have focused substantially on health at the individual level, we recognize that there are many determinants upstream that impact upon health, even at the individual level. At the level of the individual, health is determined by the interaction of beliefs which are acquired, behaviors which are practiced, and biology, which is a combination of gene-environment interactions. But a little more upstream, we find at the level of the family and the community, cultural perceptions, socioeconomic priorities, whether you're going to be spending on tobacco and alcohol or fruit and vegetables for your children. Pathways of availability and access. For example, we have smoke-free public places. Are there urban areas which are helpful for pleasurable and safe physical activity? All of those are important at the community and family level. But even more upstream, and perhaps more dominant in recent times, are the factors that are operating at the national and global level in terms of the stage and speed of development, the distributional issues of equity, and the demand and supply issues of trade. But when public health positions itself not only to be an arbiter of what is good for public, but also advocate for changes, the question is asked, what is public health? And there is a fair amount of confusion, even in the minds of people who are in the health sector, leave aside those who are outside of the health sector. John Cogan, in his book, What Makes Health Public, says there are 7 phases of public health. Public health as a political tool, as a government business, as social infrastructure, as a professional enterprise, as a conjoined beneficiaries, and as population health. I think most often we do see it as a government business of something to be delivered by a government to the people, and also as a professional enterprise of public health experts, and of population health, where public health has to endeavor in order to protect and promote the health of the population. The Institute of Medicine, which is now the US National Academy of Medicine, defined public health as what we as a society do collectively to assure the conditions in which people can be healthy. That is population health again. But there is a certain amount of naivete about this definition, where it assumes that the society will decide collectively what is good without recognizing the fact that there are several influences in society which actually have colliding interests. I don't think the tobacco industry or the industry that promotes ultra-processed foods or alcohol or fossil fuels is necessarily seeing eye to eye with other sections of society who wish to see the health of the people being protected. So it is not necessarily a collective decision. So how do we actually define public health then? In my view, public health identifies and influences the determinants of health at the population level to impact on health and disease at the individual level. And it deals with both risk factors which are a little more proximate, whether it's tobacco smoking or whether it is lack of physical activity, but it also deals with determinants which are more upstream, which drive those behaviors and beliefs. So we try and intervene using public health through several instruments, which are policy, like how do we actually control tobacco, control ultra-processed foods, how do we ensure smoke-free public places, by ensuring strong systems of organization, ensuring service delivery which is efficient and equitable, and also ensuring community action and community engagement. Quite often, the question is asked, what is the difference between clinical medicine and public health? And this has been alluded to even in my own career transition, and a question I face repeatedly. I do not believe that they are two different words. I believe they are a continuum. When a doctor or a nurse or a community health worker has a clinical interaction of examining a person with a health problem, that is clinical medicine. But what caused the disease? Could it have been prevented? Could it have been detected early? Could the referral have been made earlier? Health promotion, disease prevention, early detection and surveillance, access to healthcare services, all of them come under the domain of public health. Similarly, after the person leaves the area of clinical interaction, are referral and follow-up services available? Are enough systems available for prevention of recurrence and spread? I mean, can you isolate a person who is infected? Or can you actually ensure that the person is not going to suffer again through some other means? Affordable therapies, are they available? Whether it is drugs or even nutrition. Community services, are they organized to be supportive? So all of this is the domain of public health. So, in a sense, clinical medicine delivers health in retail, public health delivers health in wholesale because it deals with the population as a whole. We recognize that within the health system itself, there are several elements that have been described by the WHO as the building blocks. Workforce, infrastructure, drugs, vaccines and technologies, financing for health, information systems and governance. They left out people initially. But we also recognize that there are social, environmental and commercial determinants of health and nutrition, which operate at the societal level: water, sanitation, food system, environment, social stability, development, and at the personal level, income, education, occupation, social status, gender, networks, social networks. All of these act in confluence to decide upon health of both individuals and of the society where they live in. But ultimately, it is the political and economic system and the choices we make therein which determine how the health system is organized and how the social, environmental, and commercial determinants of health are controlled and steered to promote health, to enable health rather than erode health. Now, how do we ensure that health in this broader format is delivered? I think that, as William Gibson said, the future is already here. It is not just evenly distributed. Some people benefit, some people are disenfranchised from accessing the instruments of health. Therefore, how do we promote health equity? The three engines are universal health coverage, which offers financial protection for essential services. It is necessary but not sufficient. It requires also action on the social determinants of health through multisectoral action. And we need engaged and enabled communities through a rights-based approach to health. That is the tripod upon which health will rest. So let me deal with each of them briefly. Universal health coverage is where all people receive the quality health services they need without suffering financial hardship, according to WHO. The emphasis is on all people, quality health services, and absence of financial hardship. And this now is also a target of the Sustainable Development Goal 3. But then recognizing that resources are not immediately available into most countries to provide all of the healthcare needs to all of the people without any financial hardship, instead of being dismissed as a utopian concept, it has been suggested by WHO and others that we should think of progressive universalization, of realization of that particular goal. And this is portrayed in the form of a cube, a three-dimensional cube. One dimension is the population, who is covered by the UHC scheme. Second is service coverage, which services are covered in the benefit package. And third is financial protection. What do people have to pay out of pocket? How much are they impoverished? and how much of poverty reduction can be achieved by providing that kind of financial protection. Now, there is a certain amount of dissonance between the various stakeholders of society in terms of the priority they accord to each of these. Politicians would be interested particularly in the population coverage. Wider the population coverage, greater the number of voters who are pleased. Of course, I'm not saying that they're not interested in equity. They are also equity conscious. But even if the services are shallow, if the benefit package is relatively limited, they would like to see everybody covered, and everybody should be covered in any case. But healthcare professionals are interested in the service package. They believe that their patients are entitled to the very best, whether it is cochlear implant or cardiac transplantation or cancer chemotherapy. So they would like to have the best benefit package possible. On the other hand, people who are actually handling the budgets, whether in the health ministry or in the planning commissions and the Niti Ayogs, they are interested in ensuring that the resources are spent to provide the best financial protection, reduce poverty, and do all that with fiscal prudence so that the budget doesn't go bust. And there is a dynamic tension that exists between these three groups, and therefore we have to employ various methods such as cost effectiveness, burden of disease, etc., to decide what goes into the benefit package. But there too, it's not just cost effectiveness that matters, equity matters. We ought to look at equity in two dimensions, horizontal and vertical. Horizontal, where there is universal access to a common set of services to everybody, like primary care, most of secondary care, life-saving tertiary care. It has to be assured. But there is also a vertical component of equity where additional targeted services are provided or additional resources are dedicated for attending to disadvantaged and vulnerable groups to bridge the pre-existing health equities and to ensure that they are not exacerbated as we move along. Now, universal health coverage will require a purchaser, which is usually government through tax-funded resources, social insurance, which is government subsidized, employer-provided or privately purchased insurance. But ideally, they should be merged into a single-payer system to get the best out of any kind of financial risk pooling. The provider would be the public sector preferably, but there can be a participation of the private sector, the for-profit and the not-for-profit private sector, depending upon need and opportunity. And public-private partnerships are frequently being talked about. But the government cannot abdicate its role as a guarantor and regulator, even if it is not the sole provider. So the role of the government is provision through strengthened public sector and contracted private sector as needed. Public financing from tax revenues, that's the budget and social insurance programs. Pooling through single-payer systems to create the large risk pool and also thereby facilitate a bigger benefit package. Purchasing through strategic purchasing using the monopsonic power of a single purchaser with multiple providers, which is the reverse of monopoly, and utilize that to get the best advantage of services. Regulation of standards, quality, price, ethics, and education. Considering all this, when I chaired the high-level expert group established by the late and lamented Planning Commission in 2011, we recommended, the committee recommended that we adopt universal health coverage as a national commitment to be initiated in 2012 and fulfilled by 2022. Commit 2.5% of the GDP as public financing to health during the 12th plan. Prioritize primary health care for financing and human resource development and deployment. Conduct a review of all government-funded insurance schemes and propose a plan for their integration into the universal health coverage framework. Provide essential drugs free of cost because that is the most important contributor to out-of-pocket payment and impoverishment. Establish credible and effective regulatory systems for administering UHC. Enable community participation. Facilitate a focus on gender. Foster urban health services which were hitherto neglected, and act with determination on the social determinants of health. But in all this, we said primary care is the broad base of universal health coverage, as it meets all the three criteria of population coverage, service coverage, and cost coverage. It covers all people. It offers the broadest array of services. It is the most cost-optimizing type of care, and it connects closely with the community. So, for revitalizing primary health services, we said invest more in rural and urban primary health care services. Strengthen sub-centers with technology-enabled non-physician healthcare providers. Convert static facilities into near-to-home outreach facilities. Improve physical and IT connectivity between the various elements of the health system, sub-centers, PHCs, CHCs, and strengthen district hospitals. Improve referral and follow-up systems. Promote integrated care through networks of providers, particularly if we want to adopt a capitation mode of payment rather than a fee-for-service mode of payment. Enhance community participation and monitoring. Now, Ayushman Bharat has some elements of this, and we can build upon the Ayushman Bharat's various components by combining them in order to develop this kind of a service delivery system. Hitherto, we had only selective primary care. Now there is commitment to comprehensive primary care to meet all other previously unmet needs, like non-communicable diseases, mental health, etc. And in terms of secondary care and tertiary care, the Pradhan Mantri Jan Arogya Yojana is providing some subsidized care to people who are economically or socially vulnerable. But we need to connect these systems much better and use the health infrastructure mission and the digital health mission, which are the other two components of Ayushman Bharat, in a cohesive manner, so that unless we do have all of these functioning in a fairly coordinated manner, we will not be able to achieve the objectives of the mission. So, if you have a vision for health assurance, think of it in terms of three concentric circles. Innermost circle is health financing, tax, social insurance, other forms of insurance. That will provide some degree of financial protection, but that will not deliver universal health coverage unless the second circle comes into play, which are the various elements of the health system, which have to be efficient, which is a multi-layered, multi-skilled health workforce, adequate infrastructure, health management information systems, availability of drugs, vaccines, and technologies, good governance, and community engagement. But even that, the two circles combining, will deliver you universal health coverage, but not health in all of its dimensions. For that, we need the third circle, which is action on the social determinants of health, all those that we have described earlier, whether it's water and sanitation or education and gender, all of that. The entire gamut of social determinants of health will have to be influenced if we have to really deliver health to the society. And we recognize that health and nutrition are linked to all other sustainable development goals, bidirectionally in case of most of them. And we also recognize that there are bidirectional relationships between economic growth and population health. As countries prosper economically, we know from the Preston curve that as the per capita income rises up to $5,000 per capita, the life expectancy increases, though the relationship plateaus thereafter. But we also know that population health is an important investment for health, which helps to protect and promote economic growth. We also know that at the level of the individual, poverty and individual health are bidirectionally related. People who are poor are much more likely to get ill, and people who fall ill are catapulted or sink deeper into poverty. We also know that unequal societies pay a price in health. That is not just economic development of the society as a whole. How that income and the benefits are distributed within a society matters. And this we have learned from the analysis done by Kate Prickett and Richard Wilkinson in Spirit Level, which is the book they have published, though others have also contributed similarly to this kind of analysis. One of the most important lessons is that mortality is related more closely to relative income within countries than to differences in absolute income between them. National mortality rates tend to be lowest in countries that have the smallest income differences, and thus have, basically, which have the lowest levels of relative deprivation. Just compare United States and Japan, or even the United States with other OECD countries. You see the difference in life expectancy, see the difference in other social indicators, and see how the economic disparities in society also determine the health status as well as the status of many other social indicators. And most of the long-term rise in life expectancy seems unrelated to long-term economic growth rates, but much more to equality within societies. And we see this also happening across generations. If you look at what is happening in terms of low birth weight and its effects on chronic diseases, including cardiovascular disease, research done by a number of people, including our own group here in Delhi, shows very clearly that if you have intrauterine malnutrition or early infancy malnutrition, you have rebound adiposity as the undernourished child grows and is much more susceptible to develop hypertension, coronary heart disease, type 2 diabetes, and stroke in adulthood, often in early adulthood. And this even has an intergenerational impact further beyond. If a pregnant mother is undernourished, and she carries a girl fetus in the utero, the girl fetus has eggs of her own, ova of her own, oocytes. And those oocytes of the fetus are also epigenetically influenced by what is happening to the grandmother and to the mother who is growing in the womb. So it's not only the child yet to be born, but the child yet to be conceived who is blighted by this undernutrition across 3 generations. Because epigenetics can alter that. So R.H. Tawney, a British economist of 1920s and 30s, said equality of opportunity, something that Rawls promoted, is not adequate. He called it decorous drapery. He said, what is required is not only an open road, but an equal start. And for that you need to determine and influence the various social determinants of health so that people get an equal start in life. So we recognize also that there are many other elements which require attention beyond the health system. We are seeing all the effects of climate change, the effects of heat on physical and mental health, waterborne diseases and water insecurity, vector-borne diseases, extreme weather events, exacerbation of air pollution, increased risk of chronic diseases, adverse impact on agriculture and nutrition security, climate refugees. But in every case, the poor are the worst victims. So again, we have to look at everything through the equity lens as well. We also recognize that food environment, when we talk about food and nutrition, we need a systems perspective. We cannot just say it's a matter of just nutrition or health. We recognize that food transformation and retail, apart from food production, food marketing, and food demand, all of these, like from agricultural production to consumer purchasing power to market and trade systems, food transformation and consumer demand, all of these constitute the food environment and they determine the food choices. But the industry will say, not only the tobacco industry, but the fast food industry, the ultra-processed food industry, that you're actually becoming a nanny state. We prefer a libertarian attitude where the individual can determine everything and do not interfere with the individual choice. But we recognize that choice is never totally independent. It is conscious, conditioned, or constrained. Conscious by information, the right or wrong kind of information. Conditioned by aggressive marketing and promotion and cultural factors, like we have seen in tobacco and alcohol and ultra-processed foods. But most importantly, it's also constrained. You may know what is good to eat or what is good to drink, but if your pocket does not permit or if they are not available, so availability and affordability also determine. There's no point in saying that 5 helpings of fruit and vegetables a day if they are extremely costly. So these are all the factors that determine choice. So we have to act at the societal level to provide the right kind of information to the consumers, to ensure that false information is not aggressively promoted and marketed through all kinds of analytical marketing practices, and at the same time ensure that the healthy choice is also the less expensive choice. And here policing is a very powerful instrument, because policing modifies social and economic determinants of behavior through a nudge effect. It influences how people eat, smoke, and drink and move. It creates enabling environment to initiate and maintain behavior change in communities and individuals. It can impact on multiple risk factors simultaneously and reduces population risk in short time. It is cost effective. It is relatively easy to implement provided one has the political will. And it has an intergenerational benefit. You create a smoke-free society. You create good urban environments where people can walk and cycle without fearing the hazards of traffic. You create an environment with very limited air pollution. It's not just this generation that benefits. The next generation benefits too. So there is an intergenerational benefit which unfortunately our economists do not even cost when they tabulate the benefits of action and the cost of inaction. But policy does not develop sui generis. Enlightened policy needs scientific credibility, that is evidence and rationale. Financial feasibility, is it cost effective, is it affordable? Operational stability, is it steerable, sustainable, scalable? Political viability, is there a ready and receptive community, whether it's among the policymakers or among the public? Therefore, scientific credibility is aided by biomedical, epidemiological, and clinical research. Financial feasibility is elucidated by health economics research, operational stability by health systems or implementation research, and political viability by social sciences research. Finally, we need to bring in the community. When health is important to persons at the individual level, people as a collective become important to health. And we have good global models for this. In Brazil, municipal health councils, established by the Brazil's constitution in 1988, says health is the right of all citizens. It is to be provided by the state. Citizens are guaranteed the right of participation in state governance. Health councils operate at 3 levels, municipal, state, and national. And at the municipal councils, they are legally empowered to inspect public accounts and demand accountability and strongly influence how resources for health services are spent. In terms of Thailand, there is what they call a triangle that moves the mountain, which brings together the academia and other technical resources, especially at an annual National Health Assembly. So there are experts from health and other technical sectors, including health professionals, the government sector represented by politicians, local administrative organizations, government officials, civil society the people are represented by civil society, private sector, media, and traditional knowledge. And they have achieved a great deal of progress in public health and improving the performance of their health systems, both in Brazil and Thailand, through these mechanisms. In India, we have the National Health Mission, which has also incorporated some of these elements, like village-level committees for health, sanitation, and nutrition, block-level, ward-level committees, the Jan Arogya Samitis, and patient welfare committees in hospitals, the Rogi Kalyan Samitis, with the proposed public hearings annually or biannually. And the 15th Finance Commission has now is sending the resources for primary health care directly to elected village and urban local bodies, according to their recommendations. But these are well proposed, but still need to be strengthened operationally. In Nagaland, they organized Imagine Nagaland workshops to invite people to submit ideas of how the development program should be managed. The Nagaland Communitization in Public Institutions and Services Act was passed in 2002. Under that, the health communitization committees are set up, include several stakeholder representatives. They include the village councils or the Gram Buras and other citizen groups. And an evaluation, independent evaluation, has shown that the functioning of these committees has resulted in improvement in provision and utilization of services and infrastructure for healthcare delivery. But all of this will not happen unless we also develop public health expertise in our systems and programs and ensure that all these elements are brought together with greater efficiency. So we need to invest also in public health research and education. The purpose of public health research is to provide evidence-informed, context-relevant, resource-optimizing, culturally adaptive, and equity-promoting recommendations for policy and practice. And for this, we require multidisciplinarity. And we know that these are not simple things. Previously, most of research, whether in biological sciences or in social sciences, has been conducted using linear models of analysis. But we know that life is much more complex. We're dealing with multiple complex adaptive systems interacting with each other, often in confluence. And what COVID-19 has taught us is to recognize that complexity. The transmission dynamics varying from droplets to aerosol, different types of virus variants, and adapting vaccines for that, different types of drugs to be developed, the non-pharmacological interventions, whether the behavior of individuals and groups, the level of international cooperation, which has varied, and the development of drugs, and there are several unknowns. Complexity does not permit linear models. Even if you take nutritional epidemiology, previously we focused only on single nutrients. We looked at, okay, this vitamin or that vitamin or this mineral or that mineral, this fatty acid or that fatty acid. But then we realized that we were very reductionist in our approach without adequate understanding. Then we moved to food items and groups, then to composite diets, Mediterranean diet, or the Okinawa diet, or DASH diet. But we now recognize that dietary diversity is absolutely critical. And for that, food systems are critical. We need to mold the markets so that they can actually support healthy nutrition through a diversity of food, through crop diversity, through food product diversity. And we also need global nutritional governance for that. And in this